Today I'll be talking about a bit of an overview of personality disorder, current best practice, and then what the future might hold. And the presentation actually ends with the extinction of personality disorder as a diagnosis. So look forward to that surprise ending. Okay, so the plan today is, like I said, to do the brief history, to then talk about the success story of personality disorders, which is borderline personality disorder, in a bit more detail, and then in the third section I'll just talk about two of the big revisions to the diagnostic system in terms of personality disorders and how that might impact clinical practice in the future. So, personality disorders. I thought in a 1 hour talk I would start in 319 BC. There was a Greek philosopher who studied with Plato, and he wrote a book called The Characters, and in it he described 30 different personalities essentially that were problematic, and for each of these personalities he wrote a one-sentence description and then put some examples of how you would recognise these people. And actually we did a bit of a review with it this morning at work, and people actually found that it was quite useful. You have the bore, the loquacious man, the buffoon, certainly the buffoon, the superstitious man, yes, I spoke to him this morning, the nasty man, the grumbling man. The grumbling man can never enjoy anything. Nothing ever works out for him. The coward, the backbiter, the friend of rascals. So if you're interested, you can actually go onto Google and get an English translation of those personalities, and certainly we'll be using it more at the clinic, I think. One of my female colleagues pointed out that only men have personality disorders in this system. So this system actually held sway until far into the 17th century. So for hundreds and hundreds of years this kind of informed literature and thinking about personality and temperament. Really the only kind of earlier thing than this was that Confucius had a few things to say on temperament. But I thought going back that far might be going too far. So the next big thing, so that model, the characters, really held sway, like I said, for some time. And then we really get to Franz Gall's, can anyone tell me what that map is used for?
Is that phrenology?
Exactly, it's phrenology. So at the beginning of the 19th century, phrenology held this idea that different elements of temperament were actually held in different parts of the skull or the cortex. So in terms of when you think about our current understanding of mental function and temperament, they actually started to get a few things right, but of course at that stage feeling someone's head is quite different to doing a PET scan. So unfortunately that fell out of favour, but it was a big step towards our current understanding of personality. There's actually one you can find on Google that tells you the skull shape if you want a good husband. So if anyone's thinking of getting married, they can start looking at that. So the other thing we had at the beginning of the 19th century was Philippe Pinel, who was a French physician. He did a lot of work about destigmatizing mental illness. This is a painting of the unchaining. So he was very much pro unshackling people with mental illness, and that they weren't possessed by demons. There was actually a brain disorder that was affecting people with mental illness. In terms of personality, he described this disorder called Mania without delusion. So that was people with disturbances in emotions and behaviour, but didn't have hallucinations or delusions or difficulties with, like in terms of cognitive impairment. And he described one particular gentleman who got angry at a lady and threw her down a well. So that was another big recognition of personality. And certainly a very good step in terms of the understanding of mental illness moving forward. Okay, then we move to the earlier 20th century. This is Gerard Mayman's cube of personality. So he was a professor of psychology, well, what would become psychology in the Netherlands, and he was interested in empirically describing personality, and so he came up with this cube which works on 3 different axes. So he would describe personality in terms of activity level, emotionality, and whether the person was focused on immediately acting on urges or would hold off and work towards sort of thoughtful, planned activity. Also at the beginning of the 20th century, we have Emil Kraepelin, the famous German psychiatrist, essentially the founder of modern psychiatry. He again was an empiricist, so he actually looked at the brain, he looked at diseased tissue. He was very big in neuropharmacology, and he described the psychopathic personalities. So back then, psychopathic just meant related to mental health, and he saw initially, he wrote in his, I think the 6th edition of his textbook, about the 4 different personalities: born criminals, the weak-willed, the liars and the swindlers, and the pseudo-querulants, who were essentially what we would understand today as paranoid personality disorder. So that was Kraepelin was very embedded in biology and how that affected mental illness. And then at the same time, we had this guy, which I think everyone's heard about, Sigmund. So he went on to one of the main driving forces of psychoanalysis. So where you had Kraepelin looking very much at the biology of things, you had Freud talking about the sort of intrapsychic models of personality. He started describing particular clients who had anal fixation. So they were people who he theorized got pleasure from not defecating, not doing a poo, and feeling good about that. And he described if you had a child that got stuck in that stage, when they became an adult, they were characterized by stinginess, orderliness, stubbornness, and hoarding of possessions, which is effectively a description of the modern obsessive-compulsive personality disorder. So his work in psychoanalysis then informed the DSM-2, which was very informed by psychoanalysis, and led to the sort of the development in the DSM system of personality disorder. So then we get to the ICD, International Classification of Disorders, and the Diagnostic Statistic Manual. So that segues into the early DSMs. The current DSM descriptions of personality disorders. They're ingrained, enduring patterns, so they persist over time. You have behavioural, emotional, cognitive, and relationship responses that are characteristic. They're pervasive across situations. So not only do these patterns persist over time, they persist over situations. They're disabling. They stand out. The person has to stand out as unusual from the rest of their culture. So thank goodness we've got an excellent transcultural mental health team. It's not due to a medical or other psychiatric condition. So if someone's got a pervasive developmental disorder or intellectual impairment, then the symptoms the difficulties might be better explained by that. And these are effectively the percentages vary significantly across study, but 40 to 60% of psychiatric patients and 5 to 10% of the general population would meet criteria for one of the DSM personality disorders. So there are currently 10 under the DSM-5 different personality disorders. So you've got the odd people, paranoid personality disorder, irrational suspicious, schizoid, lack of interest in relationships, they can't tolerate relationships, schizotypal, so they've got the odd behaviour or thinking, but not the delusions or hallucinations that would define schizophrenia. So that's considered cluster A, the odd personality disorders. Then you've got the dramatic patients, you've got antisocial personality disorder, which is a disregard for others and rules, lack of empathy, borderline PD, instability in mood, thinking, behaviour, self-image and relationships. You've got histrionic, so they're the attention seekers. And in cluster B, you've also got narcissistic, so they're focused on self-importance, need for admiration. They also have a lack of empathy, although several models of personality disorder would argue that to have a personality disorder, you have to have a lack of empathy. I don't necessarily agree with that. Then you've got the cluster C personality disorders, which are the anxious people. So you've got avoidant personality disorder, so they're sensitive to rejection. Dependent, where they're pervasively dependent on others, they can't do things unless there's someone else to enable that. Obsessive compulsive personality disorder, so obsessive conformity with rules. Apparently they don't like to poo. So that's the current 10. So based on that, I've got a quiz. Has anyone seen this before?
Yeah.
I do find it an excellent way of diagnosing the different personality disorders. I will give you a freebie because there is one from DSM-3 that we lost, and that's passive-aggressive personality disorder, and that's number 4. He's taking up 2 parks at the same time. So does anyone want to have a guess at what number 1 up in the corner is? Yes, at the back.
Is that antisocial personality disorder?
That's paranoid. He's surrounded by 3 cars.
Oh.
Okay, any guess on number 2 with the big car? Narcissistic, correct. Very good. Number 3 is cuddled up to another car. Dependent, thank you. We did number 4, passive aggressive. So number 5. Well, actually, that's borderline. He's crashed into his lover's car to teach the lover's. But it could have been antisocial. There's, a lot of diagnostic similarity between the two. So, number 6 has deliberately parked across the parking lot. That's antisocial. Number 7 is in the centre of everything. Well, we did narcissistic, so that's actually histrionic. Number 8 is exactly obsessive compulsive. 10 is on its way out. They can't tolerate being close to any cars. Schizoid. But that is a good point, that there is a lot of overlap between these different diagnoses and their criteria. And 11 in the spaceship is schizotypal. Well done. 9 was... Oh, that is avoidant. Popped off in the corner away from everyone. Okay, so that's personality disorders. So, given all of that, now let's talk about borderline personality disorder. Yes, I chose to put Angelina Jolie as her character who's got borderline personality disorder from Girl Interrupted. So why is BPD the golden child of personality disorders? Because it is the most diagnosed personality disorder. It's the most psychometrically confirmed diagnosis. It's the only personality disorder with established evidence-based treatments for it. So when they were doing the DSM-5 stuff, and that went through a lot of revisions in terms of personality, they almost got to a point of throwing them all out except BPD and just making it an Axis 1 disorder. So, and we'll have a bit more of a talk about that after we finish talking about BPD, but it certainly is the success story of personality disorders. To the point where advocacy in the States actually got Congress to recognise that BPD, there weren't enough services for people with BPD, there wasn't enough funding for research into BPD, and they actually have a BPD day in the States. So, quick history of BPD. So people probably know that psychotherapist Adolf Stern back in 1938 talked about these patients who were on the boundary between psychotic disorders and neurotic disorders. So they would have neurotic disorder symptoms, would be quite anxious, quite upset, and then once they got really upset they then fell into psychosis and had a psychotic break, and their reality testing was significantly impaired. Unfortunately, this group of patients were also defined by the fact that they got worse with treatment rather than better, and that concept probably persisted until Marshall Linehan's DBT in the 90s. You then had Otto Kernberg, who I met, who was a great neo-American psychiatrist. He, in the 60s and 70s, he talked about, from a psychodynamic point of view, borderline personality organisation, so that there was a particular type of personality that you would see in psychoanalysis that held together as a construct, and he argued that you could treat those patients with a particular form of psychodynamic treatment called transference-focused psychotherapy, and it's gone on to be manualised and demonstrated to be effective. Oops, I'll come on forward. And at the same time you had John Gunderson, who did a lot of work at the time on establishing standardised measures to identify people with borderline personality disorder. So you then had those two forces. You had someone describing therapeutically BPD in Kernberg, and then you had Gunderson, who had discrete criteria, and that led to the acceptance of borderline personality disorder and the DSM-3 in 1980. Then towards the end of the 80s, early 90s, you then had Marsha do an RCT on a treatment of borderline personality disorder and show that it could be effective. Of course, initially DBT was for emotionally distressed women who self-harmed, and it just turned out that pretty much uniformly they all met criteria for BPD. So since the 1990s, over the last couple of decades, we've had a lot of trials, RCTs, on different treatments for borderline personality disorder. We'll talk about those a bit more in a moment, demonstrating that they can be effective. And we've certainly moved from this idea that they don't get, people with BPD don't get better, to they're likely to get better. As we'll discover in a minute, even without treatment. So in the 2010s, things are very much focused on how do you get these evidence-based therapies out to patients, and how do therapies work? What is it that gives you bang for your buck? And then the future, which we'll be talking about, is will be this system called RDoC and the ICD-11, which is coming out. So just to confirm the diagnostic current categorical criteria for borderline personality disorder. So again, it's a pervasive pattern. You've got difficulties with relationships, self-image, emotions and behaviours, and you've got to meet 5 out of 9 criteria. So you've got relationship criteria, frantic attempts to avoid abandonment, having unstable, chaotic relationships. Then you've got behavioural symptoms of self-harm, or you've got self-harm / suicidal behaviour, and you've got self-damaging impulsivity. You've got emotional symptoms in terms of affect instability, difficulties with anger, intense anger, and chronic emptiness. Some people would argue that chronic emptiness isn't an emotion-related criteria, it's a sense of self, cognitive criteria. But that's neither here nor there at the moment. And then you've got some criteria related to cognition and sense of self, which is transient psychotic symptoms and unstable self-image. So people only need to meet 5 of those criteria. So it's a very heterogeneous disorder, because you can have 2 people with BPD with only 1 criteria similarity. There is none of those criteria you have to have BPD. So just an overview, again, it's 1 to 3% of the general population. That comes from epidemiological studies in the States, the UK and in Australia. And it does depend on how you determine whether someone has the criteria or not. That can increase or decrease that number depending on the measures you use. There's this arbitrary percentage of outpatients and inpatients that comes up in everything you read about BPD. I tracked that back to the early 80s and couldn't actually find, I think it was a small private hospital in the States that they got those percentages from, but it's always quoted. It would vary very much service to service. We have a mood specialist disorders team over at PA that I work for, and so effectively we see everyone that doesn't have confirmed schizophrenia, even some people with schizophrenia, and we have even in that service you've probably got 20% of people would have a primary diagnosis of BPD. It's actually, when you look at the epidemiological studies in the community, BPD is equally prevalent in males and females. The thought is that males seek help less, and obviously a number of their means of suicide are more lethal, so often when they do psychological autopsies, they find that people have males who have successfully committed suicide probably had BPD and it was never picked up. There's also a gender bias whereby they've found quite consistently that males are more likely to get antisocial personality disorder and females are more likely to get BPD based on the same criteria, on the same symptoms. There's a high level of Axis 1 and Axis 2 comorbidity, so that also varies a lot from population to population, from study to study, but it is quite high. So there's a lot of overlap with Axis 1 disorders, not that we have axes anymore in DSM-5, but depression, anxiety disorders, PTSD. Now, PTSD is a common comorbidity, but it can be, that can vary anywhere from 30 to 70%. So you don't have to have PTSD to have BPD or vice versa. Diagnostic instability. So if you just track a whole bunch of people who meet criteria for BPD in the community, regardless of what treatment they get, 75% no longer meet criteria in 6 years. So they still have difficulties with functioning, but in terms of a coherent concept of a disease, over time, people change quite a lot. That's regardless of treatment. What you probably are seeing, like in my service, is that you tend to see the people who have got stuck in a pattern of meeting the criteria, and some of that can actually be related to the treatments we provide them and how we react to people, unfortunately. There's a high level of social and occupational impairment even after you get symptom remission, serious self-harm in about 60 to 80% of patients, and the completed suicide rate is about 10%, which certainly argues for its effective treatment. And when you think about 2% of the population meeting criteria, that's a lot of people at suicide risk just from BPD. So developments over time for BPD. So this can be quite controversial, but I think over time it's become less so, that you can identify BPD in adolescence, and it has the same course as in adults, and it can be treated. So that's well established now, and certainly in any of the diagnostic criteria, there's nothing to say you can't diagnose BPD in adolescence. Obviously you want to do that with caution, and given it's unstable over time, you want to keep an eye on that, but certainly there are patients who meet criteria, they're adolescents, and they need effective treatment for BPD. It's got a heritability of 55 to 74%. So in terms of that, so that's on average, so you can have some people where most of the contributing factors of the BPD are environmental, and some people where it's mainly genetic, but on average it sits somewhere between 55 and 74%. That's a lot less than schizophrenia. The heritability of schizophrenia is in the 90%, but it is more than depression and anxiety, which sits to your 30-40% heritability. Also means it's very common in families, and you can imagine if you've got someone with BPD in your family, you're getting the genetic and the environmental aspects of that. So just to confirm, over the last couple of decades we've demonstrated that BPD isn't schizophrenia. That was in the cards for a while. It's not depression, despite the fact that they wanted to give SSRIs to everybody in the 90s. It's not PTSD, and it's not bipolar affective disorder either. They did some large studies in the States and found that there's this huge increase in people getting diagnosed with bipolar affective disorder in the States, and they actually went and did a huge study across the country and found a lot of those people would actually meet the criteria for BPD more than bipolar. But bipolar certainly became in vogue over the last couple of years, to the point where it's getting diagnosed in 5-year-olds. And if anyone's got a 5-year-old, I mean, they meet criteria for all these disorders. They don't respond to the treatment though. Confirm that. They've demonstrated that just sitting down with someone and doing psychoed about BPD, the fact they've got the disorder, can be a treatment in and of itself. They found that self-harm can decrease. Mary Zanarini from the States demonstrated that just psychoeducation can actually lead to some improvements. But there's an underdiagnosis of BPD consistently. There's a lack of an evidence base for pharmacotherapy. So over the years, there's been lots of studies about medication and BPD, but it's very rare to find two studies that use the same measure, the same doses of medication, the same comorbidities, so there's no consistent evidence. The most the guidelines say is that you use medication to treat comorbid conditions, and you can probably use antipsychotics to try and control people's impulsive behaviour, but obviously that's a short-term outcome. Of course, doing therapy for any disorder, you want to, as much as possible, avoid benzos, because unless people are getting engaged, unless they're experiencing their emotions, learning doesn't occur, and that's quite a consistent neuroscience finding. It can be safe to treat BPD and PTSD at the same time. Obviously you want to do that carefully with the consent of the patient, but there are now lots of studies that show that people's self-harm and suicide doesn't go up consistently if you try and treat the PTSD and the BPD at the same time. Obviously you do want to prioritise your treatment targets. We've got a lot of empirically supported treatments now, and there's a greater recognition of BPD. So there were two trials of treatment for BPD. One, they weren't particularly robust trials in the 90s, but what came out of those trials was that theoretically there was this understanding that classic CBT probably didn't work for borderline patients because of its huge focus on change, that it didn't traditionally address in-session behaviour, that there weren't specific techniques for managing relationships in CBT, and that it's very focused on content over process. And it was also felt that traditional psychoanalysis wasn't a good idea for people with BPD because of the neutrality of the therapist, would lead the patient to project motivations onto the therapist and feel abandoned, that offering interpretations would be seen as blaming and invalidation, and that the passivity of the therapist would lead the patient with BPD to feel like the therapist wasn't interested. So it was felt classic CBT, classic psychoanalysis wasn't working. Then you had Marcia come along and do her randomized control trial of DBT, dialectical behaviour therapy. As people know, Marcia was behaviourally trained, so it's a very behaviour-focused therapy, looking at people's behaviour and how can they learn different skills for managing that behaviour, and she combined that with some techniques from psychotherapy in terms of a specific focus targeting on the relationship in DBT, and also incorporated some components from Zen Buddhism, which certainly helped. There's a lot of evidence again from neuroscience that shows that acceptance strategies and mindfulness can help people process their emotions and tolerate their emotions in a way that challenging thoughts or just trying to control behaviour doesn't help with. So Marcia kicked off DBT, and this is a bit out of date, this is a couple of years out of date, but dialectical behaviour therapy certainly has the most trials demonstrating its effectiveness. Then you've got mentalisation-based psychotherapy from Bateman and Fonagy. That was very popular in the UK. There is still a bit of research on it. It's a psychodynamic therapy that looks at, so it's psychodynamic but much more focused on attachment, and it's based on trying to help the patient to actually learn the capacity to mentalise, which is to step back and reflect on their own mental states and other people's mental states. Then you've got Kernberg's transference-focused psychotherapy, so that's you use the transference to look at people's concepts, unconscious concepts of themselves and others, and try to help them to resolve conflicts within those concepts of themselves and others using the transference relationship. You've got schema-focused psychotherapy, which has had a number of successful trials. So it's a development of CBT for people with chronic depression and anxiety that weren't getting better. And so Jung incorporated some experiential and again psychodynamic and attachment aspects into CBT, whereby you identify underlying maladaptive core beliefs and people's emotional reaction to those beliefs and response patterns, and you identify those, and then you use a number of techniques, including reparenting and CBT techniques and experiential techniques like imagery to help address those core schemas. You've got general psychiatric management, so that's basically psychodynamically informed case management. John Gunderson developed that, and that's had a successful trial in Canada, and it was equally as effective as DBT. And then you've got various single trials of different variants of CBT, and then in the last couple of years you've had a bit, I think there's been an ACT trial and a few other variations of treatment. So given all of that, what does all of that tell us? Like, if you've got a patient with BPD, what are you going to do? You don't have to refer them to DBT. There's a great paper by Weinberg from 2011 where he looked at the similarities between all the empirically supported treatments for BPD. So what we do know is that these empirically supported treatments are more effective than treatment as usual. People would know that comparison groups are very often treatment as usual, which is sort of an ad hoc collection of individual therapies generally. It's generally not very controlled. It's very rare that there have ever been any studies comparing two specific treatments for BPD. There was a Clarkin study in 2011 that compared transference-focused psychotherapy and DBT, and they were effectively as effective as each other, with a bit of argy-bargy between Kernberg and Marsha. And then you had a trial of schema versus transference focused psychotherapy, which found schema over 3 years was more effective than transference. But again, that hasn't been replicated. But we know that they're all effective for suicidal behaviour, deliberate self-harm, decreasing service utilisation, improving functioning, and decreasing medication use. It tells us that patients with BPD do better when they have a specific intervention for their disorder. Transference-focused psychotherapy can be manualised, and that adherence and confidence with the therapy leads to better outcomes. So the good news is all these therapies have some things in common. So they all have a clear treatment framework. How often are we going to meet? What are we going to work on? How are we going to work on it? That you discuss with the patient. They all have an attention to affect, how people feel. They all have things to focus on the treatment relationship. They all have an active therapist rather than psychoanalysis, where neutrality and passivity is needed. They all have exploratory interventions, so ways where the therapist is going to build insight and identify things between sessions. And they've all got change interventions, but obviously the different therapies change in what particular change intervention they utilise based on their model. So all the therapies effectively have, like I said, the clear framework, an active therapist, and exploratory interventions, and then they've all got attention to affect. How am I going to change things, and how do I make sure the relationship holds while I'm doing this? There are some confounds, however. Is it that all these therapies are simply more effective because they're part of research? So if a patient goes into a treatment that's part of research, they get better outcomes than if they do treatment outside of research. Because if you're doing research, there's entry criteria, exclusion criteria, patients are trained and selected, there's supervision, there's adherence measures, there's resources, standardised outcomes. So are these treatments more effective just because they're higher quality? And unfortunately that is an unanswered question. There are some differences between the manualised treatments. I won't really go too much into detail with that, but certainly I think the take-home message is that any of these treatments can be effective. Thinking about patient preference and I guess your own access to resources are the two big questions. What treatment can I get supervision or training in? And if you're able to give a patient a choice, that probably does contribute quite a lot to how they engage with it and how they respond to it. There's several guidelines on the treatment of BPD. There's NICE guidelines, there was a Cochrane review, and then there's NHMRC Australian guidelines on the treatment of BPD. As with all the guidelines, they're very vague, they're very broad. Effectively they say you should do one of these effective treatments if you can. The only sort of big thing the NHMRC says, and I believe the NICE guidelines and the Cochrane study also bears this out, is that they say, based on the evidence, when reduction in self-harm, anxiety, anger or depression is a treatment goal for a woman with BPD, then ideally you would be offering a comprehensive DBT program, ideally. That in general you shouldn't be adding pharmacotherapy because there are risks to pharmacotherapy and there isn't a lot of evidence that it helps. There are risks in terms of cardiac disease, overdose risk, all sorts of things, diabetes. So they're all available on the net to read. We're also going to talk a bit about BPD and substance use, but I'll have to skip that to get to the advancements in the next 10 minutes. So DSM-5 came out, a year and a bit, 2 years ago. Before that there was about 10 years of arguments about DSM-5 for every single diagnosis. DSM-5 was uniformly attacked for not being valid, that the working groups made up of experts and they made decisions that wasn't based on the research evidence and that they were making changes for change's sake. So the people on those working groups were all experts in their field and they all were best, meaning for the best. But as a process, DSM-5 is consistently seen as a failure in terms of reform of diagnostic systems. So what we do have now is ICD-11, which was supposed to come out 2 years ago, but is now supposed to come out in May 2018. Because as you can understand, so the ICD, the International Classification System, is the system of the World Health Organization. So you can understand when you're dealing with every nation on earth and the United Nations, it takes a lot to get things done, but it also means that you have to have a system that is simple but useful enough that you can use it, and this was pointed out to me, in a little village in Africa, you have to be able to use the ICD system. In Siberia, in the Congo, it has to be a system that's usable in a variety of different circumstances. Whereas the DSM is designed by psychiatrists for psychiatrists. It is a specialty manual. So there's some reforms for the ICD-11, and then the other system we have is the National Institute of Mental Health in America. Their recent director, Tom Insel, he's a psychiatrist and a neuroscientist, and he has put forward that, unlike DSM-5, we should be integrating neuroscience findings and our understanding of the brain with our diagnostic systems for mental disorder, which really brings us all the way back to where we started. I'll just go into a little bit of detail with these two systems. So the existing problems with the categorical system of, this is me every morning in the corner, the problem with the existing categorical systems. So in the current systems, pathological personality has no connection to our understanding of healthy personality. So if it's a personality disorder, there should be some connection. So in healthy personality study, you talk about personality traits. We don't do that in the current personality disorder model. There's extensive diagnostic overlap between all the different personality disorders. It's very rare to find someone who only meets criteria for one of them. Most personality disorder categories ignored. Like I said, if you have a personality disorder that's been identified, 97% of the time it's borderline personality disorder. Occasionally you might get antisocial, and then all the others get personality disorder not otherwise specified, because this is too difficult to, and is it clinically useful to identify the different diagnoses. So clinicians aren't discriminating between personality disorders. Sometimes there's more difference within personality disorder than between personality disorders. Like I said with BPD, you can only have one. You can have one criterion similar between two patients, and they've both got the same personality disorder. There's no role of personality disorder severity. So at what point is it a difficulty, and at what point is it a disorder? The categorical diagnosis artificially increases a gap between someone who's got just personality and someone's got a personality disorder. I talked about DSM-5, and then even with our best treatments for BPD, the golden child of personality disorder, more often than not, you're still getting less than 50% people completely recovering. So we've still got a lot of work to do in terms of improving the effectiveness of our effective treatments. ICD-11, which is the working group for that, is driven by Peter Tyrer from King's College in London. He's quite outspoken. He's a very bright guy. He has a lot to say about personality disorder. He's suggesting a new model in ICD-11 where, based on the scientific evidence that personality variation is dimensional from healthy to pathological, that rather than 10 different personality diagnoses, you just have personality disorder. And that you rate personality disorder based on severity levels. So you determine the severity level in terms of the problems, the extent of difficulties in interpersonal functioning, difficulties with awareness of self and understanding others, the consequences of those difficulties to them in terms of jobs and long-term relationships, and the risk to self and others. So based on that, you get a model that looks like this. So you wouldn't diagnose schizotypal personality disorder. You would say the person has a mild personality disorder, or they have a moderate personality disorder. And the severity, because in the UK, and Peter's from the UK, they have a stepped model of care. So this model then leads you to connecting the intensity of your intervention to the severity of the personality disorder. You don't have to provide a full DBT program for 12 months for 4 hours a week for anyone with a personality disorder. You rate them on the difficulty of the severity, and then, for instance, if it's mild, you may give them some psychoeducation and some brief cognitive interventions. If it's moderate, you do brief cognitive interventions. You might do less intensive versions of the evidence-based psychotherapies, and it's only when someone's severely personality disordered that you would do your full group and individual programs. The other aspect of this model is that the awareness that there are personality traits that go from normal personality into personality disorder, but rather than, there was a DSM-5 proposal that suggested listing people on 76 different personality traits. People just said, no one's ever going to use that, no one's going to have the time. But look, they did a big, let's go forward, they did a big factor analysis, and what they found was that all the different personality traits in the healthy and pathological personality disorder literature fell into 4 big domains. So as well as severity, you could then specify which of these 4 domains, maybe all 4, that the person might have difficulty in. So there's the emotional domain, so, histrionic, narcissistic, borderline sit heavily on this domain. So that's a tendency to evaluate and respond negatively to the self-world and others. Underlying that, is there a neurological emotion regulation system that's out of whack? There's an antagonistic domain that's particularly people traditionally with antisocial would fall in. Sometimes people with borderline would fall into this domain, so that's disregard for obligations and conventions. There's a detached domain. Anxious avoidance sits in that, so that's social indifference, inability to experience pleasure. And anacastic, which is effectively OCPD, so that's over control. So all the different traits fall in those. People probably see your classic 5-factor model of personality dimensions. Emotionality is neuroticism, antagonistic is being low on agreeableness, and so on. So what that helps is it leads you to a model that then helps you determine which particular treatment. So severity is helping you decide how intensely to provide it. Where they fit on these domains helps to determine which particular therapies. So the DBT, schema, mentalization, transference, those are particularly effective for people sitting in the emotional domain, not necessarily the other domains. Antagonistic, you can help people control their behaviour using some CBT approaches. There is some evidence for that. Using containment, you're locking people on, and anti-androgens. For anarchistic, CBT and SSRIs. For detached, now it's interesting because we see a lot of people with BPD that present very differently from each other, and certainly you do have the detached avoidant patients who would sit in the detached domain, and they're actually very hard to engage in therapy. Often they don't present for therapy, for treatment, and if they do, it's hard to really get them to emotionally engage in the treatment effectively. And the suggestion is maybe these patients would benefit best from nidotherapy. So nidotherapy is effectively, it comes from I think it's from the Latin for nesting, and it's the idea of helping the environment and the person match as much as possible. So rather than trying to change the person, because that's going to have limited effectiveness, it's actually looking at their environment going, well, how can we improve this person's quality of life given the situation? But certainly someone could come in high on all of them, and you then have to figure out what to do. So that's ICD-11. Am I going to get cut off in 4 minutes, Rod? I just wanted to briefly talk about the other huge diagnostic model that's coming through. So just briefly, the benefits of the ICD-11 model is that it's a simple system to use, better selection of patients for treatment in terms of intensity and the type of treatment, decreases stigma because you've got that spectrum from normal to severe personality, and WHO is doing a lot of work on validating these domains and developing tools to help clinicians use the new model. So that's ICD-11. I'm very pro. I can't wait until it starts. I think it'll be really helpful for us in guiding treatment and diagnosis. The next huge change is from the states, from the National Institute of Mental Health. So that's the federal body that funds all the mental health research in America, unless they go, there are some other models, but this is primarily the organisation that defines research into mental health in the states. And they've suggested that, hey, remember we used to talk about the brain and its role in mental health? Well, it's not in any of the classification systems anymore. We've now got these great expensive machines that are actually helping to inform treatment. We should incorporate and integrate neuroscience with mental health and actually look at so this is the idea of using information from genetics, neurobiology, behavioural science, people's environments and people's experience, tie all those things together to look at the underlying mechanisms that aren't working when someone presents with a mental health disorder or a mental illness. And again, this would look at those systems in healthy people, and then as people start to have problems, what's going wrong. An example is, in mental health we talk about depression. There's actually a lot of variety in terms of people with depressive symptoms. If you go to a GP, they don't say, and with a cough, they don't go, you've got coughing disorder. And so we're going to give you a medication for coughing disorder. Because you could have heart failure, you could have just walked through some smoke, you could have asthma, you could have some sort of immunological problem, you could have asphyxiated on your drink on the way in. There's lots of different causal mechanisms explaining those symptoms. And so generally in health and in medicine, you don't say, yeah, you've got the symptom disorder. I mean, in the DSM, I think trauma disorders are the only ones that suggest the specific cause for the symptoms people are presenting with. So what they've done is they've done some initial work at looking at these different systems that can go wrong when people have a mental illness. And there's 5 different domains. So RDoC stands for Research Domains Criteria. So what the National Institute is saying is that they will no longer fund research into schizophrenia. They will no longer fund research into depression. What they will do is fund research into the fear system, or into the working memory system, or in terms of the attachment system. So in the States, to get funding, they're now looking at these underlying causal mechanisms. So people wouldn't have BPD, borderline personality disorder, in this model. They would have difficulties with the anxiety system, which is anticipated threat. They might have difficulties with the loss system. So the loss system is related to when you get some bad news, and how you biologically deal with that, how you cognitively deal with that, how you emotionally deal with that. People with BPD could have problems with the cognitive control system in terms of impulsivity and being able to redirect resources into controlling their behaviour, and they might have difficulties with the attachment system. So rather than looking at BPD, you would go, okay, well, what different problems is the person having, from genetics all the way up to their experience, what might be contributing to that. So at this point in time, it's very new, it's very focused on research, but it's at this point they're going, really, look, we need to look at what are the underlying mechanisms. There's been some great studies recently come out in terms of depression, where at Stanford they've identified you can use MRI scans of people's amygdalas and a measure of trauma in their childhoods and predict who's going to respond to antidepressants and who isn't, with about an 85% accuracy rate. And what it turns out is if you've got childhood trauma to a degree and an amygdala that isn't working under stress, then those people generally don't respond to antidepressants, and you need to look at other interventions. So that's very new. There is an example I'll put there if people want to look up the Siegel paper, but essentially it was looking at the loss system and giving people a trigger in terms of some negatively emotional laden words, looking at physiological measures of how people with BPD didn't calm down after those triggers, and the fact that it was actually their experience of their emotions using the BDI rather than thinking symptoms that were associated with that. So that leads you to feel that it's maybe better to focus on emotion regulation than challenging thoughts for people with BPD. So again, just the RDoC system's very new. It's not specifically designed clinically at the moment, but certainly at Metro South we're looking at how can we incorporate more of this model. It's also very transdiagnostic because emotion regulation, say as an example, is consistent across anxiety, depression, borderline personality disorder. So you can start looking at transdiagnostic treatments rather than having all these specialist treatments. Okay, so I guess it's just to be aware that in terms of patients with BPD, there are very established ways of diagnosing people with BPD and treating that. And in terms of the particular therapy, I think it is more about the quality of your treatment than the particular model, if you're picking one of those many models. And in terms of the future, thinking about the severity of people's personality dysfunction and then doing formulation about, well, what is it specifically that this person's having trouble with coping, functioning. And then there's some balloons. Thank you for persisting.
We might still have time for one or two questions, if that's okay. Nathan, your point about diagnosing BPD in adolescence, what about the aspect of criteria that symptoms must persist into adulthood?
It specifically states that it can be, well, it actually says, well, what the definition of adulthood isn't specified. And certainly the specific criteria within the DSM manuals specifically talks about diagnosis in adolescence and that you would do it with caution. So in terms of whether it persists, that is a good point. And as we've seen, BPD itself for anyone may not persist. I guess what they're saying is that there's probably enough evidence to start making some informed decisions about what treatment you're going to provide someone when they start persistently, pervasively presenting with those difficulties. And I don't think the diagnosis of BPD is as stigmatizing as it used to be. I mean, in the past that meant you would never get help if you got BPD, whereas now it means that you can get help and it's likely to be effective.
I was just wondering, for those people who could be suitable, who are suitable for therapy to start, I mean, the problem that could exist there is that more often than not you may have a coexisting alcohol or other drug problem. So does that, I guess depending on the extent of that, does that exclude them from therapy at that time until that's resolved, or can people start into therapy?
So the evidence on that is that in general, having a comorbid substance use disorder doesn't decrease the effectiveness of standard dialectical behaviour therapy. It still works. Of course, you have to make some decisions about what treatment is primary. If someone needs effectively detox because they can't actually engage, then that's a practical decision that needs to be made. But I guess that would be for any treatment. The other thing about, say, dialectical behaviour therapy is that there's now a specific module focused on substance use, which I talk about in the slides I didn't cover, and that's gone through some trials, and that's shown that that's incorporating those techniques has made DBT even more effective for comorbid substance abuse and BPD. That's in DBT version 2.
May I ask, with obsessive compulsive anarchistic personality disorder, what Freud would have called anal personality disorder, that explains the organised hoarders. I can't get my head around the disorganised hoarders.
I guess I can only refer you back to Freud. I mean, it's not a 100% overlap. I guess the idea was that there were some concepts within that conceptualization that do overlap with our current understanding. I guess the other thing is that, as we've seen, the organised and the disorganised hoarders really understanding whether their similarities and differences are probably at the early stages as well.
It looked like in ICD-11, I couldn't quite see where the old cluster A personalities were going to fit.
So some of those haven't had a lot of validity psychometrically over time. So like I said, they are reviewing whether some of them are already accounted for by the other disorders. It would be worth, though, did I give I think I gave a Tyra reference, and he certainly talks about the overlap between the existing categories and the new system. And again, that's all being worked out as we speak in terms of how that's going to map out.
Can I also ask another question, which is, we see a lot of people that would have significant personality disorders but wouldn't threshold DBT in public outpatients. Are any of those therapies deliverable in your 10 sessions a year Medicare rebatable, or is it just not available for most of our patients?
So I do know that some of the NGOs are providing aspects of DBT. They're offering the skills group, so there's a couple of NGOs providing that. The other thing is that the recent behaviour tech trainings, that's Marsha's group, have actually started to identify that perhaps DBT could be modular. For the longest time, for decades, we sort of had this idea that the 12-month full program of what was evidence-based, so that's what we should be providing, but certainly the research is now looking at the individual components of DBT and who specifically those components might help. And certainly there was the trial where they compared full DBT to just individual DBT to group DBT with case managers, and they found that that full DBT and group DBT with case managers was pretty much as effective, although the full DBT held on to patients longer. So there's also an argument that it is in DBT specifically the skills. If you can keep someone in treatment, then it's doing the skills which might be helpful. And I think that's one of the rationales for why some of the NGOs are offering just the skills group, because if they can get their individual therapy of any sort somewhere, as long as those dovetail, then the skills group is probably going to be quite helpful. And just in terms of those cluster A people, I'm pretty sure they end up on they often fall on the detached spectrum.